Hello, everybody. Welcome to another Research Nexus. Today we have Dr. Jack Westfall come back and talk to us about how to form an advisory group at community health centers. Dr. Westfall practices family medicine in addition to his policy work. He was the medical director for whole person care and health communities at the Santa Clara County Health and Hospital Public Health Department. For 2 decades, he was a faculty member of the University of Colorado Department of Family Medicine, where he started the High Plains Research Network, a geographic community and practice based research network in rural and frontier Colorado. He also served as an associate dean for rural health, Director of Community Engagement for the Colorado CCTSI, AHIC Director, and Senior Scholar at the Farley Health Policy Center. His research interests include rural health, linking primary care and community health, and policies aimed at assuming a robust primary care workforce for rural, urban, and vulnerable communities. He's also a consultant for an ATS for our institute for a long time. Welcome, Dr. Westfall, and thank you for joining us today.
Okay. Hey, so it's Jack. Can you all see this? Not the same 10 people creating a patient advisory group? Awesome. So thank you very much. It's very nice to be here. I always enjoy my time with you all, and sorry to have missed the conference this year. I'm hoping to catch up with Jane and some of the projects that they have going on. Today, though, we're going to talk a little bit about engagement, patient engagement. I've done this really for about 25 years, engaging patients, engaging community members in participatory research and clinical work and quality. And frequently, what happens in the community is that the same 10 people raise their hand and get picked for everything. And whether, I grew up in a small town, and so, I get my hometown paper still, and I work a day a week in my hometown. And the 4 of the 5 candidates for the city council are exactly the same as they've been for the last 25 years. And there's finally one young kid who said, I decided I was going to pitch in, what the heck. But it's typically the same 10 people. I grew up in a church. And I attended church, and you ask somebody, you ask for volunteers, and the same 10 people. Well, what we want to do is we want to get past the same 10 people. There's a whole line of people there that we can access, and I think it's sometimes important to just think beyond the same 10 people. Now, you all need a patient group. I think Section 330 of the Public Health Service Act says that FQHCs are required to have a patient or consumer representation among their governing board. Patient advisory councils have become much more common over the last 10 to 15 years, particularly with the advent of the patient-centered medical home and the National Committee for Quality Assurance. And then there are other people who just want to engage patients because they just want one for good measure. They just think it would be nice to have the people that are experiencing our healthcare, the people who are seeking our healthcare, the people whose lives are changed by the care they receive or the research we do, might ought to have some input. So today, what we're going to do is I'm going to give you a little overview of what patient advisory groups can do. We're going to talk about the naming of patient advisory groups, what activities they can do, and then some work that I've spent, 10 years on defining the characteristics of the just right patient for engagement. And this is a paper that we've been working on for 10 years. Sometimes it takes a while to publish a paper. We haven't even written the paper yet because we've still been gathering data, and our community members have moved us beyond the just right patient to the just right researcher. So now we're doing a sister project with the just right. What are the characteristics of the just right clinician or researcher? And then we're going to do a deep dive into a case study of a robust patient community advisory group that I've been working with for 20 years. What are the successful activities? What are the recruitment strategies? What's the care and feeding? And I'm hoping that from that deep dive, you will be able to see some of the activities or actions or strategies that you all can take as you think about developing and actuating a patient advisory group. So finding more than the same 10 people. So the first question is really what's the name of this group? So there's patient advisory group, there's patient advisory committee or a board or a council. And each of those has a little bit of nuance for what the expectations are. A group, it's a broad definition. There's no formal power or authority. And so, if you think about what's the role of the group, are they advisory? Are they accountable? Do they have power? A committee, is more of an advisory and a working group. They tend to be much more in the weeds. They typically report up to a formal board of directors or an executive team. A patient advisory board tends to be a little bit more formal. And I think the language from the Public Health Authority may say board, but I'm not sure that that's the way that most of them are actuated. A lot of them don't necessarily have authority to make decisions. Because remember, FQHC is making clinical decisions. And so having a group of community members that have 51 votes out of 100, that may not be always the way to, they may vote to stop doing vaccines. Well, okay, that may not be something that you want. So a board, you want to be careful with a patient advisory board. A council, again, it's advisory, but maybe a little bit more gravitas. It's a little more influence. Or use another term. Use whatever term you want. But define the roles and expectations. So when you start inviting people, and we'll talk about how to invite people, think about what's the role and expectation, because you don't want to say, oh yeah, this is a board and you get to vote on everything, and then they come onto it and they want to change the name of the clinic, and you're like, well, we're not changing the name of the clinic. So and then from the first word of that, patient advisory, is it a patient? Is it patients? Is it community members? Is it a citizen advisory? Is it a public advisory? And throughout my work, groups choose all different types of these. So our group actually said, well, we're not just patients. We are patients, but we're not just patients. Sometimes we are just community members. We live in the community. We go to school. We go to the grocery store. We get gas. We're community members. One of the feds tend to use public because they want to make it clear that they're not hired. They're not government officials. They're public participants in an advisory group. It used to be citizen was a common one, but it's become a little less common now because it has such a reflection on whether somebody is a citizen of the United States or they're documented or not documented. And sometimes the very people you want aren't citizens in the formal sense. So that one's fallen out of a little bit of favor. However, groups still use it because it's sort of that citizen scientist, the non-professional person who gets to help do the professional work. Any questions on? I'm happy to take questions during this, or you can put them in the chat. I don't think I can see the chat right now, but if you have questions, please, we can stop and talk about them, or we can do it at the end, however you want to do it. Okay, this is Honest John. Brothers and sisters, after many years of the same old ward leadership, we realize it's time for a change. That said, will the same 10 people please stand with their names called and swap their callings? That happens a lot. So why have an advisory group? Well, there's a federal requirement. And then maybe this is the reason I do it is because it makes the work more relevant to the folks in our clinic, our community, and our organization. So while there are requirements, there's so many organizations. I've worked with so many FQs that do this only because of the federal requirement. It's the minimum, and it's really very meaningless, honestly. And so if you're going to do this, I strongly encourage you to really embrace it and think this will make your work better and your organization better. So what are they good for? Why haven't what can community members do? Well, so this is from the American Academy of Family Physicians. They have a couple of papers out. There's the citation down below, and they talk about patient advisory council input, and it's a whole lot of things that they can do. Enhanced patient communication, design welcome packets, rethinking an advanced medical directive program. So it could be something as broad as what the packet is when somebody first shows up at the clinic to something very specific around a medical directive program, suggestion boxes, a receptionist checklist for greeting. How do you say hi to people? How do you bring them in? Um, planning a secret shopper activity. That one always makes clinicians nervous, but it's quite fun to have some of your patients become secret shoppers, either by calling in or actually showing up. They can participate in physical improvements to the space. How do you make the waiting room? What kind of vending machines? Clinic signage. We did a big project with patient engagement years ago where we ended up changing all the signage to be in English and Spanish. Um, Quality improvement. This one's a little tougher. This one, if you have a good, strong quality improvement program within your clinic setting, um, it's uh, it's not easy, but you can bring patients and community members into that already uh, ongoing structure. I wouldn't start with quality improvement for patient engagement because it if you don't really understand the working of the clinic, then participating in a plan, do, study, act project can be a little daunting and put people off, or they get so excited that they again change the name of this clinic and change the entire structure, which maybe doesn't always work. So here's some examples. Clinic leaders have decided to double the size of the clinic. They're looking for the best way to publicize that. And so their patient advisory council participated in that. Patient satisfaction of the front desk were low. Oh my gosh, very common. How do you welcome people in? And that's a nice, it could be a quality improvement or simply uh, what what works for people when they come into the clinic. So there's some actual examples of this. I'd encourage you to take a look at the AAFP article on this. Well, who are these so-called advisors? So I'm going to talk a little bit about engaging the just right patients and community members. This is the research. What are you looking for in patient advisors? We've been doing this for a number of years. We were looking for people that, maybe volunteer or maybe they get paid a little stipend. And what we did was we engaged 5 different groups that we've worked with to help us identify the patient and community member characteristics associated with successful, engaged research and clinical work. And we really worked with these groups, and we just put up notepads and took notes, and we had dozens of pages of notes from each of these 5 groups. It started with the longstanding Patient Advisory Council, the Community Advisory Council of the High Plains Research Network. But then we also did it with the Colorado Research Network. We did it with a boot camp translation facilitator training. We did this with a Montana group of community transformation training. And then we did it with the NAPCRAG patient and clinician engagement. What are the things that make for successful engagement? What are those characteristics? And this might be something that you and your team want to undertake as you're thinking about who to get. And because it's a fun little practice to see what are those characteristics, and we'll just go over those characteristics. These are the groups that did this. Very diverse from all over the country, old, young, racial, ethnic, age, disease, um, different groups. They are not the same 10 people. So this Mike Hernandez is in the middle on the lower end. Anybody know what he's one of our community advisory councils, and his t-shirt says, "I may not have a PhD, but I do have a DD214." And this is one of my favorite pictures because it shows about the not same 10 people. Anybody know what a DD214 is? That's an
Nope.
honorable discharge from the
Hmm.
military. So he's a vet, and he doesn't have a PhD, but he is absolutely an expert in living in his community and accessing care. So he's got that expertise. He's got a DD214, and that helps think about the not same 10 people. So, what are those characteristics? Here's the list of them that they boiled down to. This was from dozens of pages from each of those five. So 50 or 60 pages of comments. We boiled them down and then we vetted them back. Curiosity, willingness to listen, some basic healthcare experience and knowledge, some experience in the community. They have to have time. If it's a busy person that just can't show up, that they may be a great person, but if they don't have time to participate, then they're not helpful. Maybe time to travel because if your clinic is across town, they have to be able to get there, whether that's by bus or car. This next one is crucial. And this is why sometimes the first person to raise their hand is the person that you encourage to come and be a volunteer to welcome people to the clinic rather than be part of your advisory, because sometimes the first person to raise their hand has a personal agenda. I'll never forget, we had a hospital board member in one of the towns I worked in, and he had had to wait 4 hours in the ER one afternoon when he had low back pain, and he was so mad that he ran for hospital board because he said, "I'm going to change it." And he was so obstinate when he got on the hospital board because he'd waited 4 hours for low back pain. And so a personal agenda can kill the group process. We've the groups thought that a sense of humor is important. Somebody who can both laugh at themselves and laugh at the situation. Somebody who's not so serious that any problem becomes a major problem. One of the characteristics is a sense of purpose, that they're doing this out of a sense that they're doing something important. And that requires both a good engagement to begin with and a recruitment strategy about what's the purpose of the group, but also substantial care and feeding to make sure that their sense of purpose continues to get actuated. So somebody joins thinking, "I'm going to help make a difference." And then you don't follow up. They don't see any progress. They don't get notes or agendas. They don't get minutes from the notes. And suddenly they're like, I don't know why I'm here. It seems like I'm here just to drink a cup of coffee and nod. So a sense of purpose is both important for recruiting folks and for ongoing engagement. Somebody who can think outside themselves. It's not just about them, their diabetes, their children. It's somebody who can think about the benefit of the broader community and think in other people's shoes. Okay, I don't have diabetes, but can I think about what it means for somebody who has diabetes to come into the clinic? They have to come in every month. Oh my gosh, we need to make sure that when somebody has to come in every month because of their medical condition, that should be a nice experience. And then somebody who can speak humbly. This gets to sort of all these willingness to listen and curiosity and being able to speak up, but not in a this is the only way to do it manner. Any questions about those characteristics? Awesome. Okay, so what can the Just Right patients and community folks do for you? So I like John Steinbeck, and East of Eden is one of my favorites. So you're going to see a few quotes in here from John Steinbeck. There's a responsibility in being a person. It's more than just taking up space where air would be. And it's important that your community members know that their the world will be better, your clinic will be better, the work that you do will be better if they're there than if the room were empty. So patient advisors participate. So I like to think of the sort of groundwork of participatory research and participatory engagement in work, because it really helps understand that patients and community members are experts. So we use the term community-based participatory, and it could be research or it could be clinical advisory. Um, and it really helps that they become part of the clinic, part of the leadership, and their ideas are important. And they become experts. So while you have an expertise in running the clinic or in being a physician or being an administrator, being a researcher, we really try to also point out the expertise that our community members and patients have. They are experts at getting to the clinic, at getting their kids to school, at working in the community. And so honoring the expertise that everyone has is important. Here's some things that we've done. This is a woman teaching about home blood pressure, and this is our patient advisory group learning about home blood pressure so that then they can help the clinics implement home blood pressure management in a way that's much more meaningful and accessible to the patients than other than just saying, hey, go get a blood pressure cuff and start taking your blood pressure. Um, here's the group. Again, be curious, not judgmental. This is one of my favorite lines from a recent television show. But this is the group meeting at the church, and Yuma really thinking about being curious, having curiosity, and listening to each other around what can be done for their community. We have high schoolers. These are two high school students that helped participate and advise us on a community mental health project. How could community members and patients um, become part of the integrated behavioral health within the community? So integration, typically, we think of having behavioral health professionals in the primary care setting. The community members and the patients really helped push us beyond what happens in the exam room and in the clinic to making sure that the messages that they hear in the clinic are echoed by messages that they hear out in the community. So while your patient advisory council is geared towards making sure the clinic is running well, one of the other aspects is how do you make sure that what people hear in the clinic and their activities in the clinic are reflected in the culture and the language that is used in the community? Well, what's it really take? So, getting a patient advisory group is not easy. It takes what we call windshield time. You got to get out of your office. You got to drive to the grocery store, the coffee shop in Eastern Colorado at 6 a.m. at the coffee shop where the old farmers gather to talk about crops and farming. So whatever that is for your group. There's one here in Denver as well. It's not farmers, it's just a bunch of older people gather at 6 a.m. Silver sneakers, go to the mall on cold days when the silver sneakers folks are walking the mall, or on very hot days. in your neck of the woods where they can go to the mall and walk in air conditioned um, uh, mall, it's important to be able to do cold calls. You have to be able to call somebody you've never talked to before. Oh, I have to take Tums because it's always a little nerve-wracking when I'm about to call somebody I've never talked to get my 30-second explanation of why I'm calling in before they hang up. I think I'm a telemarketer. A friend of a friend of a friend is a great way. Hey, Bill, John gave me your name and says that you like to do X. You're interested in blood pressure. You're interested in he said maybe you have some thoughts about diabetes. Um, when we get together, we always have food, and we had a great member who could bake coffee cake, and she couldn't make coffee. And so I would try to show up before her because she grew up in the Depression. And so she made very thin, watery coffee. And I like mine very strong. Um, I've done this talk in Wisconsin and Minnesota. And so you have to learn to like lutefisk and lefse. But whatever that is in your community, that unusual or cultural food, it's important to think about how do you bring that in. We did get in trouble one time. We were doing a patient advisory group, and we hired a local caterer, only to find out that actually they were not a documented immigrant, and we had no way to pay them because it was out of the university and they didn't have a legal way to pay them. So that was a tougher one. Here we are thinking about our advisory group, thinking about a strategic planning. So we went and the group learned about what was going on in the clinics and in the community, and then they used those stickies and they all wrote stuff down. And then halfway through the day, we started prioritizing using the number of stickies. And so having them think about. So this is again the care and feeding. These people are already on our advisory. How do we have them give a sense of purpose? We help them by listening to their strategic planning. And you can see in the background there, elderly, patient doctor, healthcare operations. Those are some of the things that they think about. And as they move forward, as they've been here for a year or two, they start thinking very sophisticated about the care. And in fact, we did a big project with this group on patient-centered medical home and the benefits of the patient-centered medical home. And after learning all about the patient-centered medical home, they were like, that doesn't sound like patient-centered. That sounds like doctor-centered medical home. Everything you just said was doctor-centered, and how can it be patient-centered? So we actually then spent 9 months doing a study, and we used appreciative inquiry to identify their experiences with both healthcare and other businesses. One of the people was like, when I go to my um, mechanic, they know my car. They know what it's had. They have a list of all the things that it's had. They never ask me when my last oil change was. How many times have you gone to the doctor and they're like, well, when was your last blah, blah? And you're like, can't you look in the medical record? And so they started this list of what were the characteristics of the patient-centered medical home based on what were the characteristics of a human-centered other business. And they boiled it down. They have all these quotes, and they boiled it down to patient-centered medical home is relationship. And if you have relationship, then and but that's that purpose. That's that care and feeding. So again, it's participatory. It's ground up, limits of expert knowledge. You know a lot, Aaron. Deb, you know a lot. Marie, you know a lot. Jane knows a ton, but you don't know everything. And you don't know everything about the 3 bus lines that people have to take to get to your clinic. They do. They know about the fact that in their neighborhood there's no reliable childcare. There's not a park. So they become experts, that they bring that expertise to you. Oh, we've talked about this. Takes time and energy. Now, I've started this uh, little campaign that says stop building trust. That's my new mantra. Stop building trust. Be trustworthy. So everybody says, well, first, you're going to read creating a patient advisory, build trust. Well, to heck with that. Stop building trust. Be trustworthy. If you are trustworthy, if you do what you say, if you say on this date, I'm going to have the agenda out. And on this date, I'm going to have the minutes for you. And when you come, we're going to have a nice, comfortable space and I'm going to have a snack for you. When you guys make a recommendation, we're going to figure out how to implement that. Suddenly you become trustworthy and they're like, yeah, I trust you. Patient advisors may innovate. So sometimes they come up with ideas that are outlandish and innovative. When our food and clothing and housing are all born in the complication of mass production, mass method is bound to get into our thinking and eliminate all other thinking. Now, in medicine, this happens all the time because you've got your RVUs and you've got your ICD-9s and your E&Ms and your all that stuff, mass production, that gets into your thinking. And somebody comes in and says, well, how about this? How about a group visit for people with low back pain? Oh my gosh. So we did a project on colon cancer, and they wanted some catchy phrase, so they used the term "got polyps." It doesn't really transliterate into Spanish very well. So in Spanish, we use "polipos prevenga no los tenga." Talk to your doctor. But then we used local people to carry that message. It wasn't famous people from other places. It was people from their clinic, people they recognized, people they knew their names. We used, I truly believe moving amongst sectors is incredibly valuable. So as you're thinking about who to invite, this is a recruitment strategy. Think about people who bring in a different perspective, somebody from the education, somebody from the schools, somebody from the Chamber of Commerce who thinks about business, somebody from um, the community college, somebody from retail business that broadens the perspective. So it's not just a bunch of people getting together yahooing about public health and immunizations and blood pressure checks. It's somebody who's like, well, if you're going to get people to do blood pressure, how are you going to get them all to pay for blood pressure cuffs? How are we going to do that? And how can we set up a fund to make sure that anybody whose insurance doesn't pay for a home blood pressure cuff would would be able to provide that? So different perspectives important for the recruitment of your advisory. And then this is just showing how when you engage people, they engage people and they engage people. And if you look at the top, we had 10 in our community advisory council. We added some for this particular 13 more for this particular colon cancer project. But then that group ended up recruiting 229 other people to help with the dissemination. So as you're thinking about um, your advisory group, think about who are the people who know other people. And this is that whole network theory that came about in the 40s and 50s in Iowa farmers. And how do you take advantage of that? There's a really good book by Malcolm Gladwell um, called, oh, which one was it? Tipping Point. Tipping Point. And our group actually read that book. Our advisory group read that book. And some of them, there's different types of people, and one of them is a maven, somebody who the community trusts, somebody who that if Mrs. Jones says something, people believe it. Then there's other people who are connectors, who they just know 10 different people. Oh, they're like on MASH, the guy who could get stuff. He always knew how to get a radar. He always could get the things that people needed. Advisors will create. So our advisory group really wanted to tackle asthma. And they said asthma, it's really common. And so they helped us create, and this is one of those places where they combined both the clinic and the community work so that the work in the clinic and the community were identical. So it was called Asthma Toolkits in the clinic, and it was practice training and these toolkits that were produced in English and Spanish, adult and child. But then they wanted to get out into the community, and so they did a sister project called Community Air, Community Asthma Integration and Resource. And that really took those same messages with the same color scheme, the same words, the same language out into the community so that both places people were getting the same. This was some of the materials that they came up with to put up around in the schools. And of course, they told us that anything with the kids, this is the local volleyball team. They said anything with kids, they can't be smiling. They have to be scowling because if they're smiling teenagers, the other teenagers won't even pay attention. They have to be scowling. So that's why the volleyball team there is they're all scowling. They wanted provocative stuff to get people's attention. Triggers, which is that was quite a, and then innovative stuff to get messages out. They did T-shirts and they put them out, um, and then they engaged students to help with a golf tournament. And for this one, we started up here at the top with 5 staff and 11 community advisory council members. We expanded it to 20 for our asthma advisory council. And that may be something you think about. You have your core advisory group, but then if you're thinking about a particular project, hey, we really want to focus on the entry and the reception, both physical and how people are welcomed, you may bring in a few more people just for that project who know something about that. But those 20 people ended up recruiting over 700 people in the communities to get the message out around asthma, both in the clinics and in the practice. And here's the result. In Eastern Colorado, there's the dark green. During the intervention, the hospitalizations dropped dramatically in Eastern Colorado and went below the rest of the state. So this stuff can work. When you engage patients and community members in the work of the clinic, it can actually make a difference. Well, again, what's it really take? Travel time, space. Oh, so yeah, we hadn't talked about space. So you really need to have a space. Now, a lot of clinics do have a space, but not every clinic has a space. Can you use the waiting room? I suppose, but um, uh, if your community advisory council or your patient advisory council thinks that they're a tack on, that they're not really that important, um, they're less likely to then invest their own energy. If you're not willing to invest in a space, and so maybe you don't meet at your clinic, maybe you meet at the community center down the street or at a local church or a local organization that has a boardroom or a room that can make your group feel special. So that space to meet is crucial to build the credibility of this group. Compensation. Now, I'm not sure what the rules are around compensation for FQHC community advisory councils. Our community advisory council essentially does this as volunteer work, but whenever we can write them into grants or projects, we do pay them. We always provide food, we provide childcare, and we provide transportation because those are allowed expenses, but sometimes we can actually offer them an honoraria as well. This was a cool project that the community came up with. They wanted to do something on obesity prevention, but they didn't want to use the word obesity. And so they came up, this was totally derived from their experiences. They recruited high school kids to teach fifth graders. They'd been to a conference and had heard about photo voice. And so they said, let's get fifth graders to use photo voice to look at healthy and unhealthy activities. They did a project on cancer survivorship, and they two kids there's last year. We want to do a manual, like a tractor or an automobile manual. So this is built on a on the idea of an automobile technical manual that can go in the glove box. Advisors produce. So sometimes they get a little bit proud of themselves. They do something good and they're like, hey, let's do a little video production of this. And so here they are, producing lights, camera, action, producing a little video that then can be shown in the community and in the practice to folks to sort of, again, heighten the awareness and the credibility. Oh my gosh, Sergio is not just the guy that is at the hardware store. He's he's a spokesperson for colon cancer. Wow. Okay, I'm gonna listen to him. And next time when he talks about mental health, our next project, oh, well, Sergio was trustworthy on colon cancer. I'm going to listen to him around mental health. Community members C. You are one of the rare people who can separate your observation from your preconception. You see what is, where most people see what they expect. Oh my gosh, this is such an important component of community advisory councils. And this is something to look for as you're interviewing people and talking with them. Do they have this ability to observe, or are they coming in with preconceived notions? Do they have an agenda? Do they have something that they already think, I know what the clinic needs. The clinic needs this. Or can they come in and observe and be part of an exploration and then think about what happens? So one of the things we were working on, I said, was mental health. And Sergio, the guy in the wheelchair in the previous picture, um, we had the head of the mental health clinic in the room. There were about 18 people here at this group. And he said, Liz, Centennial Mental Health is not a safe place to go. And she was devastated. She was like, what do you mean not safe? And he said, well, I am a small business owner. I drive a pickup. And if people see my pickup at Centennial Mental Health, they'll think something's wrong with me, and that may impact my business. And so I need somewhere else to go. And so this was part of a big project around thinking about how to integrate behavioral health into the clinics and into the community. So creating safe venues for emotional expression in the community. Wow, that's changing the status quo. We think of integrated behavioral health as, either the collaborative care model or getting behavioral health clinicians into the practice. Community members and patient advisors believe in all that. And how does it also leave the front door and go out beyond the community? This is the work that, when you're doing the work of patient advisory councils, sometimes it's messy. What, when, where, and who, and how do you do this? And did we want to focus on suicide or depression amongst who? Adults, kids, farmers, ranchers, and the patient advisors really help hone that focus and that strategic plan. They inspire. So they really wanted to do, you saw earlier on, this home blood pressure program. And so they said, what we really want to do is get more people doing it and get the practices to do it. And so they came up with a name, Just Check It. And they said, you check your oil, you check your crops, check your blood pressure. And then they did a project in Spanish language as well, and amongst Latinos. And this stylized skeleton is a popular. Sorry, my slides keep auto forwarding. This stylized skeleton is a popular image in Mexican American culture in Eastern Colorado, and they said, well, let's take advantage of that and get people to think about blood pressure. And here they are inspiring at a practice. These are two, this is a nurse practitioner and a nurse at one of the clinics. And they inspired these clinics to really take on home blood pressure management. Advisors share. Here's a couple of the folks around the asthma going to one of the local radio stations. Again, moving out of the clinic and into the community. Well, what do our community members tell us that they want? This reflects on some of the characteristics, but also the care and feeding of that group. They want a sense that they're doing something important, something that matters, something with purpose. They want to feel that what they're doing is helping you take better care of them. They want movement. Boy, this is the hard part. Man, when they expect you to move forward with a project, and if a couple of meetings go by and you were too busy to do your homework, and you come to the meeting and you haven't done your homework and they've done their homework, couple of times like that, and they're going to start wagging their finger at you and, say, hey, we're here. You got to commit at least as much as we're committing. Our community advisory council wants to see the results. So if you're doing something on patient satisfaction, they want to see the results. They want to know what was the outcome. They want to share stuff. They like to go out and share. So here they are walking at a Relay for Life, and here they are dancing. Oh, wait, that's me dancing. That's Shirley Cowart, one of our patient advisors. I don't know why this is automatically going. They tend to follow us around and go to a lot of meetings with us. They present stuff, and sometimes you can put them in front of other groups. And boy, the credibility of your clinic and your patient advisory when a patient is actually providing the talk about what you did on your quality improvement, unbelievable. People really, that builds credibility. But folks keep their day jobs. This is not their work. This is not their life. They are advisors. And so it's really tempting to, get somebody from the hospital, somebody from public health, somebody from the early childhood council, somebody from the area health on aging, people who their job allows them to be here as part of their job. That is very tempting to do that. And maybe you have some of those people, but true advisory groups need to have some of these other folks, farmers, ranchers, school teachers, retired folks, small business, students, who their day job is not your work. They have their own day job, but they bring in a level of expertise that can inform and add additional thoughts to the work we do. So I'm going to end with, here's the characteristics of the just right patient: curiosity, willing to listen, basic healthcare knowledge, time to participate, able to travel, no personal agenda, sense of humor, sense of purpose, think outside themselves, put themselves in others' shoes, and speak humbly, as things that you're looking for as you start recruiting. And then that care and feeding that we talked about will carry you through.
That was awesome, Dr. Westfall. I learned so much. There's so much to think about. And you highlighted so many great things. So thank you so much.
You're welcome. I'm happy to take any questions or listen to comments or anything that you have to say or ask or tell. Aaron, you're starting an advisory group at El Rio, or you have already?
So we do have some ongoing groups at El Rio in the patient advisory capacity, especially with our Special Immunology Associates Clinic, which is dedicated to serving our patients with HIV and AIDS. And then our community outreach department has different groups that they convene for different purposes. And then we also have 10 of our 17 board members at El Rio are also patients. And so what I've been tasked to do is to create um, based on the language slide you shared, probably a group would be the name for it, a patient advisory group focused on helping to guide the research initiatives at El Rio. We are a teaching health center and also house the Southern Arizona AHEC. And as a result, we find ourselves doing a lot of research in family medicine, dentistry, pharmacy, a lot of different areas. And we are kind of at a tipping point where it's almost like grasping at straws for residents and students to come up with unique projects because we've had these programs for so many years. And so we really want to start bringing in the patient voice and the community voice to really guide research initiatives, learn what they're interested in. And, we're within the past year, we've also more so established research as part of the grants department at El Rio. We're trying to put a little bit more power behind all of the work we're doing in that arena. And so I'm a little bit before even step one in getting this established. And so this was a really helpful talk. And I'd love any, experiences you can share. It sounds like the groups that you've worked with have initiated a lot of actual programs, research, QI things. And so I'm curious if you have any feedback, advice, if we should, kind of what our first step should be, because
Yeah, it's a combination. Sometimes a funder comes, like the CDC had put out a call for projects on colon cancer prevention. And our
Okay.
community members were like, yeah, that sounds good. And that went very well. And then the community members said, well, that went really well, but asthma is the big thing. Asthma is such a big problem. Can we do something on asthma? So then we looked for a year, found funding. It took a while. And then we did something on COPD. And then one of our community members, actually a high school student who was waiting tables, had a person passing through town that he was waiting tables on who was suicidal. And he came to the group and he said, I have no idea what to do. And that's not adequate. That's not, we have to do something. So we spent the next 2 years studying mental health and ended up developing a program around mental health. So it's a combination of stuff that they come up with, stuff that we come up with. And one of the ways that we did that is we about every decade now I think we're due one because we're 20 years into our community advisory council. We do a strategic planning day, and we have a half a day where we hire somebody to come in and give us all the data on the community and, the BRFS data, hospital data, demographic data. And then in the afternoon, we just brainstorm on what are the topics and issues that the community's facing. And then we create out of that a top 10 list. And I think the first time we did it, it was a top 10 list. The second time, I think it was a top 10 list that had 14 things on it. But community is always right. So it ended up with 14 things. And then we don't necessarily just go down in order because sometimes funders don't care about those top 10. They have funding priorities. So we pick things from that top 10 list to do. And then other times there's a funder that has something that's not on the list. And we go back to the community and we say, hey, what do you think about this? And sometimes they say, no, we're not interested. And other times they say, yes, we are interested. But I just put something in the chat for you to think about coming to NAPCRAG and our PACE, Patient Clinician Engagement Group. It's been around for 10 years. It's a group of folks who their day job, they have day jobs, but then they participate in research from all over the country, North America, Canada, and some from Australia and New Zealand as well. But it's quite a fun group. If you could come to NAPCRAG next fall and meet them, and we usually do a pre-conference where we do some training, and it would connect you. Maybe you bring one of your patients, because these are oftentimes dyads with a clinician and a patient, or a researcher and a patient. But it's quite fun to think about. And they're one of the groups that helped come up with those characteristics of the just right patient. But
This is
it will
great.
connect you with some of the other resources that are out there for doing the work that you're doing.
That's a great resource. Thank you. I'm going to look into that.
Jane, have you been to our pre-con? Jane's been to NAPCRAG a lot, but have you ever been to the pre-conference, the patient-clinician engagement?
I have not had that opportunity.
Okay. It's a fun day.
I have appreciated at the NAPCRAG meeting when experiencing patients from patient advisory groups talking about what they do, and seeing their engagement inspires me.
Last NAPCRAG, I think in San Francisco, there were probably 80 people who would have identified themselves as patients or community members. They're not clinicians or researchers. And they're busy. They're there. They're presenting posters and talks. They come by and they say, why does this matter? What's the point of this talk? What's the point of this poster? What's this research? What's this project? And so it's a great place to sort of see the breadth of skills and expertise that patients can bring and expand that thought of sort of what can patient advisors do.
Definitely. Thank you.
Well, I think it's we're 2 minutes before, so I will turn it back over to whoever's running this show, and I'll go on mute. And thank you so much for inviting me. I really appreciate it, and look forward to hearing, Erin, how things go.
Yes, I'll keep you updated. Thank you.
Thank you, Dr. Westfall. There is a brief survey after we close this meeting, so please, if you have a few minutes to take that survey, we'll appreciate that very much. And if you have any questions, please feel free to reach out to us, and we can pass on your questions to Dr. Westfall. Well, thank you all.